right, medicos, let's dive right into this high-yield clinical explainer. Today, we're deconstructing a scenario that frequently traps students and, honestly, even seasoned residents on the wards and the boards. We're talking about the silent killer, a clinical presentation that completely, and I mean entirely, masks a massive, life-threatening cardiovascular event. Picture this. You're on shift, and a 58-year-old diabetic patient walks in complaining of nothing more than just a little bit of fatigue. You get them on the monitor, and you see a baseline heart rate of 52 beats per minute. So what is your immediate, absolute first pharmacological move? I want you to lock in your answer right now, because making the wrong choice here isn't just a small error. It's a classic, fatal mistake that we unfortunately see happen far too often in emergency settings.
We're going to treat this exactly like a senior attending ward round. Here is our clinical roadmap for today. 1. The clinical case presentation. 2. Decoding the missing pain. 3. Diagnostics and the emergency. 4. The treatment trap. 5. The undeniable first line. And 6. High-yield exam synthesis.
Okay, let's jump straight into part 1, the clinical case presentation and the glaring anomaly.
We've got Ramesh Patel, a 58-year-old retired farmer. He's got a 10-year history of type 2 diabetes, currently managed on metformin and glipizide. He tells you he's been feeling fatigued with just some mild jaw discomfort for the past couple of days. But here is the glaring anomaly. There's absolutely zero classic crushing chest pain, no radiation down the left arm, nothing. His vitals, though, that's a different story. His blood pressure is elevated at 148/94, and his heart rate is severely bradycardic, sitting at 52 beats per minute. The alarm bells in your head should be ringing loudly right now.
Moving to part 2, decoding the missing pain. Why on earth is this classic hallmark of ischemia completely missing?
Well, Ramesh isn't just being tough or stoic. It's actually a textbook physiological roadblock. We are looking at diabetic autonomic neuropathy in action. Over a decade of chronic high blood sugar has physically severed the patient's internal alarm system. His heart muscle is literally screaming for oxygen, but his brain? It simply isn't receiving the message.
Think about it at the microscopic level. Normally, healthy nerve fibers transmit pain signals from the starving heart right up to the brain. But with diabetic autonomic neuropathy, chronic hyperglycemia has literally eroded the myelin and destroyed those visceral afferent fibers. The electrical signal physically fails to reach the brain. It completely turns a raging myocardial infarction into a silent, stealthy killer. It's terrifying, right?
So, since we can't trust the pain scale, let's hit part 3. Diagnostics and the emergency. We need the objective truth.
Getting that 12-lead ECG gives us our first massive red flag. Right away, we're seeing a new left bundle branch block, or LBB, pattern. And crucially, checking the lateral leads, specifically V4 through V6, you can clearly spot significant SD depression. The myocardium is actively starving right in front of us.
Then the cardiac biomarkers come back from the lab and confirm the emergency. We've got a troponin I level of 2.8 nanograms per milliliter. Now keep in mind, the normal reference range is less than 0.04. So to put that into perspective, this sky-high troponin, combined with those ECG changes, firmly locks in our diagnosis of a true NSTEMI. We have a massive cardiac emergency on our hands, no doubt about it.
Which brings us to the hot seat. Part 4, the treatment trap. How do we avoid a fatal mistake here?
Think back to our initial question. Based on his bradycardic heart rate of 52, what's your immediate pharmacological move? Are you reaching for option A, the beta-blocker atenolol, option B, the opioid analgesic morphine, or option C, the antiplatelet aspirin? Let's break these down because I promise you 2 of them are massive traps.
Say you reach for morphine reflexively because, well, we're all taught it's the standard for cardiac pain. Actually, you've just triggered a deadly cascade. Morphine causes sympathetic activation and venodilation. That drops the preload, which directly leads to decreased coronary perfusion. In a heart that is already begging for oxygen, decreasing perfusion actively worsens the ischemic injury. Plus, you've got the added risk of respiratory depression.
Honestly, you know that classic MONA protocol we all memorized? Morphine, oxygen, nitrates, aspirin? Yeah, it's officially dead. According to the ACC and AHA 2023 guidelines, morphine actually increases mortality in NSTEMIs based on Crusade data. It should be strictly avoided unless there's refractory pain. And oxygen? That's now strictly given only if SpO2 drops below 90%. If you're still running the old MONA reflex, you're practicing outdated, dangerous medicine.
Okay, so what if you chose option A, atenolol?
Another fatal mistake. Atenolol is a negative chronotrope and a negative dromotrope, meaning it slows the heart rate and slows AV node conduction. Giving that to a patient who already has a baseline sinus bradycardia of 52 will throw them straight into a third-degree AV block, cardiogenic shock, or even frank-asystole. The golden clinical rule is this: beta blockers are relatively contraindicated in acute coronary syndrome if the heart rate is under 60.
All right, let's get it right in Part 5, the undeniable first line, our anchor.
The only correct choice is option C, aspirin 325 milligrams chewed immediately. That is your undeniable first-line anchor in this scenario. And why is this so incredibly safe for Ramesh? Because aspirin has absolutely zero chronotropic effect. It's not going to touch his heart rate, meaning it won't worsen his baseline bradycardia one bit.
Notice the specific instruction there, though. Chewed. Chewing the pill is a massive clinical pearl. By crushing it in the mouth, you get rapid buccal absorption directly into the capillary bed of the oral mucosa. That completely bypasses the liver's first-pass metabolism, meaning the drug hits the systemic circulation and goes to work in under 30 minutes. Remember, time is muscle. Chewing buys us time.
And here's the really beautiful pharmacology behind the strike. Aspirin irreversibly acetylates the COX-1 enzyme, stopping thromboxane A2 production and halting platelet aggregation. But the real kicker? Platelets lack a nucleus. So once aspirin permanently blocks their COX-1 enzyme, they can't just synthesize new ones. They are permanently disabled, out of the game entirely for their full 7 to 10 day lifespan.
So why do we give that massive 325 milligram loading dose right in the ER? It's all about rapid saturation. You want near immediate, maximal platelet inhibition while the ACS is actively ravaging the heart. That much lower maintenance dose of 75 to 150 milligrams you prescribe later, that's just to mop up the roughly 10% of brand new, fresh platelets trickling out of the bone marrow every single day.
Obviously, aspirin doesn't fly solo. Once it's chewed and in the system, you seamlessly transition to the rest of your modern evidence-based arsenal. You initiate dual antiplatelet therapy, DAPT, by adding an oral loading dose of clopidogrel. You push a high-dose statin like atorvastatin 80 milligrams, which is absolutely crucial for stabilizing the plaque. And finally, you start anticoagulation with heparin to stop that clot from propagating any further.
Finally, let's wrap up with Part 6, high-yield exam synthesis. Let's make sure you beat the boards.
Whether you're tackling the USMLE or the NEET PG, examiners absolutely love laying this trap with beta blockers and ACS questions. They'll give you a diabetic patient with vague jaw discomfort, an ECG showing ischemia, and then quietly slip in a heart rate of 52. They want to see if you reflexively reach for standard ACS meds without checking vitals. If you do, you'll miss that atenolol is contraindicated, because again, giving a negative chronotrope to a bradycardic patient is lethal. Always verify the heart rate and blood pressure before selecting a beta blocker or a nitrate.
So take a mental snapshot of this whole framework. Remember how painless MIs present in diabetics due to autonomic neuropathy? Remember your undeniable first move, chewed aspirin for that irreversible COX-1 block. And remember the traps. Morphine worsens outcomes and beta blockers are out if the heart rate is under 60. So I'll leave you with this. Are you ready to spot the next silent killer when they walk onto your ward complaining of nothing but a little fatigue?